Living with a chronic condition often feels like being an expert in a language nobody else speaks fluently. When it comes to adrenal insufficiency, that gap between clinical data and lived reality is particularly wide. We're looking at a deep dive into an article from My Adrenal Life by Kristen Distler titled What Long-Term Adrenal Insufficiency Patients Wish Doctors Understood. It is a powerful exploration of the nuances that don't always show up on a blood test, but define the daily existence of those navigating this condition.
It really highlights a fundamental tension in modern medicine. Doctors are trained to look at snapshots, lab results, short appointments, specific metrics, while patients are living through a continuous, high-stakes movie. For people with primary adrenal insufficiency, like Addison's disease, or secondary and tertiary versions, the missing hormone is cortisol. And as the National Institute for Diabetes and Digestive and Kidney Diseases points out, cortisol isn't just one thing. It's the body's primary stress response hormone. It regulates everything from blood pressure to how we process nutrients. When that system is broken, life becomes a constant balancing act.
The article makes a distinction between what a doctor sees as inconsistency and what a patient sees as variability. If a patient comes in 1 month feeling great and the next month they're a shell of themselves, a clinician might see that as an unstable or non-compliant patient. But Distler argues this is actually a predictable unpredictability. Is it even possible for a condition defined by the lack of a stress response hormone to be static?
Not really. Human life is dynamic. According to the National Institute of General Medical Sciences, our bodies follow strict circadian rhythms. Cortisol naturally peaks in the morning to wake us up and drops at night. But it also has to surge when we're scared, sick, or even just exercising. In a healthy person, the HPA axis, that's the hypothalamus, pituitary, and adrenal glands, handles this automatically. In someone with adrenal insufficiency, that automation is gone. They're basically flying a plane on manual controls during a storm. What worked yesterday might fail today because the storm, the stress load, has changed. It's not that the patient is being inconsistent. It's that the environment is constantly shifting and their body can't keep up.
That leads into a concept from the article that I found fascinating, the stacking effect, or accumulation. It's the idea that stress doesn't just happen and then go away. It builds up, like a game of Tetris, where the blocks aren't disappearing. Why is this so hard for the medical establishment to quantify?
Because most clinical models look at acute events. If you have a broken leg, you fix it and it heals. But with adrenal insufficiency, small stressors, a bad night's sleep, a minor cold, a stressful deadline, don't necessarily resolve. They linger because the body doesn't have the hormonal resources to reset properly. A patient might handle 3 small stressors just fine, but the 4th one, which might be tiny on its own, becomes the tipping point that causes a total crash. To an outside observer, that crash looks sudden and disproportionate. To the patient, it's the inevitable result of 3 days of stacking. Research in the Journal of Clinical Endocrinology and Metabolism has actually looked at these self-reported health outcomes and found that quality of life is often lower than doctors assume, specifically because of this cumulative fatigue and the fear of the next crash.
It seems like there's a massive amount of data being lost because it's labeled as anecdotal. Long-term patients develop this hyper-awareness, a kind of pattern recognition. They can feel a crash coming before their blood pressure even drops. But if they tell a doctor, "I feel off," and the labs look normal, they're often dismissed. That creates a huge psychological burden, doesn't it?
It's incredibly isolating. When your lived experience is treated as noise rather than data, you stop trusting your own voice. Distler points out that for long-term patients, this isn't just guessing. It's an internal early warning system built over years of trial and error. This is where the concept of patient-reported outcomes becomes vital. The NICE guidelines in the UK have started to emphasize the importance of identifying and managing adrenal insufficiency, not just through chemistry, but through the patient's ability to function in daily life. If a patient recognizes a subtle warning sign like a specific type of fatigue or dizziness, that is a clinical data point. It's just one that hasn't been traditionally valued in a 10-minute office visit.
How do we bridge that gap? The article suggests some practical ways to communicate this to a medical team. One that stood out was tracking patterns instead of just symptoms. Instead of saying, I was tired on Tuesday, you say, I had 3 days of high activity, and by the 4th day, I couldn't get out of bed. That frames it as a recovery issue, which is something a doctor can actually wrap their head around.
Specifics are the bridge. Using phrases like, everything caught up with me, or I'm recovering slower than expected, helps translate the feeling of accumulation into a clinical context. It moves the conversation from, I feel bad, to, my body is failing to adapt to stress. Another strategy is bringing a written summary. Appointments are fast, and when you're low on cortisol, brain fog makes it hard to advocate for yourself. Having a timeline of a flare-up, showing the lead-up, the event, and the recovery time makes the stacking visible. It turns the invisible struggle into a tangible map for the provider.
We should also talk about the different types of adrenal insufficiency mentioned. While many people think of Addison's, which is primary, there's also iatrogenic adrenal insufficiency. This is caused by long-term steroid use for other conditions like asthma or arthritis, which eventually tells the body to stop making its own cortisol. Is the experience different for those patients?
The root cause is different, but the daily reality of HPA axis suppression is very similar. The Endocrine Society provides specific resources on glucocorticoid-induced insufficiency because it's actually quite common, yet often overlooked. These patients might have a partially functioning system that works sometimes, but fails under stress. That makes the variability even more confusing. They might go weeks feeling normal and then hit a wall because their body couldn't mount a response to a flu or a surgery. The stacking effect is just as relevant here, but there's often less education provided to these patients compared to those with a primary diagnosis.
The article also touches on pacing as a management strategy. It sounds a lot like the spoon theory used in other chronic illness communities. It's about recognizing that a good day doesn't mean you're cured, it just means you have a slightly larger window of energy to manage carefully. If you spend it all at once, you're just inviting a stack-induced crash tomorrow.
Exactly. It's about reducing the variability by choice. If you can keep your routines consistent, you minimize the number of unexpected blocks falling into your Tetris game. But that requires a lot of discipline and, frankly, a lot of grace from employers and family. When a patient has to cancel plans because they sense a crash coming, it's not a lack of interest, it's a medical intervention. They are literally trying to prevent an adrenal crisis, which can be life-threatening. The more a medical team understands this proactive management, the more they can support the patient in staying out of the emergency room.
It seems the ultimate goal here is validation. The article ends by telling patients that they aren't overthinking their experience, they are living it. There's something very powerful about acknowledging that a lab test is just one perspective, and the person living in the body has the other, equally valid perspective.
It's the move toward a partnership model of medicine. The doctor is the expert on the science, but the patient is the expert on the application of that science in their specific life. When those two experts work together, the outcomes are significantly better. Studies on quality of life in adrenal insufficiency consistently show that when patients feel heard and are given the tools to adjust their own treatment within safe boundaries, their health outcomes improve. They aren't just surviving, they're actually managing the condition.
This whole discussion really centers on the work of Kristen Dissler. Her journey and her ability to articulate these complex internal states are helping a lot of people feel less alone. For anyone navigating this, her YouTube channel, My Adrenal Life with Kristen, is a deep resource for seeing these concepts in action. It's one thing to read about accumulation, but another to see how someone manages it in real time.
And it's important to remember that while this is educational, it's not medical advice. Every person's HPA access or lack thereof is unique. The key takeaway is that your observations are data. If you notice a pattern, it's real. If you feel a stacking effect, it's happening. The challenge and the opportunity is finding a way to share that data with your medical team so they can see the full picture, not just the snapshot.
It's about moving from a place of frustration to a place of advocacy. When you understand why your energy fluctuates or why you crash after a busy week, you can stop blaming yourself and start managing the biology. Adrenal insufficiency might be invisible, but the strategies to handle it don't have to be. By bringing these nuances into the exam room, patients are actually helping to evolve how the medical community understands chronic hormonal conditions.
It also highlights the need for more research into the long-term physiological strain of living with AI. We have the life-saving medications, hydrocortisone, fludrocortisone, but we are still learning how to help people thrive, not just survive. Insights from patients like Disler are the roadmap for that future research. They point to the gaps that the current clinical metrics are missing.
We've covered the variability of the condition, the way stress stacks up over time, the importance of valuing lived experience as data, and practical ways to communicate these realities to doctors. It's a complex topic, but at its heart, it's about the human element of medicine, understanding that the patient is the most consistent witness to their own health.
And that witness has a lot to teach us. Whether it's recognizing early warning signs or understanding the long recovery times after a minor illness, these are the details that define a life with adrenal insufficiency. It's a journey of constant adjustment, but with better communication and mutual respect between patients and providers, it's a journey that doesn't have to be taken in the dark.
If this perspective on the hidden complexities of chronic illness resonated with you, consider sharing this episode with someone who might need to hear that their experience is valid.